Uh, Hello, hi everyone, online, every doctors and nurse. Tonight, it's my pleasure to be co-moderator for the excellent lecture. I'm Dr. Wang from Beijing, China. I worked Peking Medical College Hospital. I'm an ICU doctor. Um as we all know, COVID-19 from epidemic to pandemic become severe and severe. I think lots of doctors, maybe ICU doctors, nurses, pay more attention to the COVID-19 epidemic and pandemic. So in the week past last, my colleagues from CCUSC, Chinese Critical Ultrasound Study Group, take three excellent lectures about COVID-19's treatment and diagnosis and treatment based on critical ultrasonography. We acquired a lot of good respect and good requirement for the next for the continuous lectures about COVID-19's diagnosis and treatment based on the critical ultrasonography. To my joy, tonight we have two colleagues as co-moderate. It's my honor to maybe invite them, introduce themselves one by one. The first guys, my colleague is Professor Cao Yangong. Hi, Professor, it's your turn.
Okay, thank you, Xiaoting. Hello, everybody. I'm Dr. Yangong Chao. I work in Beijing Tsinghua University Hospital, and I'm also an intensivist ICU doctor. As a moderator tonight, I'm grateful to be here to talk about COVID-19 with all of our international colleagues. I hopefully we can send some very useful information to all of our colleagues to fight this disease together. Thank you, Xiaoting.
Okay, it's my honor to invite another moderator come from China, Professor Zhu Ran. Hi.
Hi. Good evening, dear colleague. I'm Dr. Zhu Ran. I'm attending from the first affiliated hospital of China Medical University. It's nice meeting you all in this webinar. That's all. Thank you, Professor Xiaoting.
Hi. It's my pleasure to invite Professor Zhang Lina to take a lecture tonight. I think she will take an excellent lecture about the COVID-19, especially in the pandemic time. So let's begin.
Hello, everyone. Good afternoon, my friend from Italy or other Europe countries. And good evening coming from Asia. I'm Dr. Lina Zhang. You can call me Lina. I come from Xiangya Hospital, Central South University, Department of Critical Care Medicine. I'm now working in Xiehe Hospital at Wuhan for 47 days, responsible for training with COVID-19 critical patients. I'm very like to communication experience with fellows for all over the world. My colleagues, Dr. Zhu Ran, Yin Wanhong, Chao Yangong, had gave the topic of respiratory management, circulation management with critical ultrasound for COVID-19 patients, and lung ultrasound imaging features for COVID-19 patients on 10 years ago. Today, I will give my topic of stratification and earlier warning of critical events with critical ultrasound in COVID-19 patients. I think it may be very important for us to manage COVID-19 patients. we know the World Health Organization characterized COVID-19 as a pandemic at 11 March. It is serious condition distribution all over the world. By date of reported and WHO readiness through 24 March, nearly 37,000 people confirmed, and more than 16,000 people died. So in my mind, preventing mild or ordinary case from developing into critical illness and the early warning of abnormalities is important for us. First, we need to understand the physiological characteristic. It would be helpful for us to make full sense of physiologic change and lung emissions. This is the first pathologist in the world of the COVID-19 patients. It is a patient suffered from lung cancer and then have a lung surgery. After the surgery following, he became from COVID-19. From the pathological tissues, it suggests the early stage pathology of COVID-19, mainly include atrophy and severity of alveolar epithelium, type 2 pulmonary cell hyperplasia, and protein-like exudation with granules. After that, it was subsequently found in the pathological anatomy of the number of the died cases. It's from this pathological, we see the progressive stage that diffuse the intra-alveolar hemorrhage cell embolies to fill the alveolar cavity. So we see that the COVID-19 patient, first invasion of the epithelium cell, alveolar then pulmonary interstitiation injury, induced acute lung injury, and hemodynamic and inflammation effect, aggravated of the lung injury, oxygen delivery disorder, then more organ injury. Just as the picture shows, viewers involved alveolar epithelial cells. It mainly targets cells in the early stage. Rapidly, the alveolar exudation, progressive pulmonary interstitium exudation. The patient may have a severe hypoxia and dyspnea. The body shows abnormal reactions. And now, improper respiratory and circulation intervention. The secondary lung injury developed. But the role of the circulation factor granting list appears is late. So we named it the superior epithelial cell secondary injury. In these patients, it very obvious the virus directly infect the lung, cause the respiratory failure and dyspneas. So it need to be distinguished with the sepsis, which is the circulation factor act obviously. Its target cell is mainly endothelium cells. So we call it the superior endothelium cell secondary injury. So we know that the basis on the article that had been published online in the early COVID-19 spread, Dr. Sang Yu found that most of the patients, acute lung injury, respiratory failure is the main clinical manifestations and management important things. Compared with the survivor patients, the non-survivor patients have the lung propagation for mechanical ventilation, both invasive and non-invasive, and ECMO. The rate of the oxygenation index was significantly lower in non-survivor groups at only 6 to 0.5. How to prevent it from the patient developing into critical illness? Avoid the event of the emergency of the COVID-19 is very important. How to definition critical COVID-19? It may be proportion is %10. Its clinical manifestation mainly have the 3 aspects. First, it's continued aggravation of pulmonary injury after virus infiltration. Secondly, have the serious respiratory failure. After that, secondary condition of circulation deteriorated and mortal organ injury. So, when we talk about how to prevent from the patient developing into critical illness and avoid the event of the emergency in COVID-19 patients. What is the emergency event? We demonstrate is the moment of the suspicion event before the death of the COVID-19, such as the severe respiratory failures, shock, cardiac arrest, sepsis. As all of the ICU doctor knows, 2 main aspects we need to note is the circulation and the respiratory. In China, as it's known to all Chinese ICU doctors, we always talk about there are no sudden changes, only changes detected suddenly. That means we need to monitor the patients and to earlier warning what's happened for the patient and preventing the sudden change for the patient. First, we talk about the respiratory emergency events. Respiratory emergency event focus on the following 4 areas. How about the lung lesion infected by virus? Is it serious? Is it getting better or worse? Are there airway obstruction? Is it spacing and respiratory driver and fewer cavity occupation? So first, we see I do recommendation you use the lung ultrasound to assessment the lung lesions. We know a normal erected lung permits visualization of the anterior chest wall from scan to the peripheral. The lung and the pathologic states are amenable to ultrasound analysis by virtue of the interplay between air and the fluid with the sorrows. The oral propagation of which suggests distinctive process. My colleague Chao gave the lecture about lung ultrasound image based on COVID-19 CT scan and pathology, as we know. From the COVID-19 CT scan, we detail to see that it have the ground glass, oxidative infiltration, consolidation, and fibrosis. Its development over time of its meaning and survivors. We can match the lung ultrasound imaging with the CT scan. So the vascular cyto thinking in the CT scan, the mean being just A-line in ultrasound. And the single ground glass cyto, maybe in the lung ultrasound, is B7 local. And the multiple ground glass saddle may be the B7 scatter. From the CT scan, when the large multiple ground glass saddle from the ultrasound may be B7 multifocal. Diffuse ground glass saddle may be the large regional B7. If the patient have the exudative saddle that from the lung ultrasound, maybe it is B3. If CT scan is diffuse infiltration, maybe the lung ultrasound is confronted B line. It is always very common in the COVID-19 patients. From the CT scan, when it's a consolidation that from the lung ultrasound, it may be multifocal small consolidation or the airborne truncates, or sometimes have the tissue-like signs. So, when the dynamic change of the ultrasound, can dynamic assessment disease progresses in COVID-19 patients. When the patient is very serious, that the lung ultrasound is obvious. We can just say this patient is the 70 years old patient. He had the dyspnea and confirmed the COVID-19. When he came to the hospital, his heart rate is 19 beats per minute, and the respiratory rate is 25. SpO2 is 93. When he had the nasal tubal to 6 liters of minutes. We do the ultrasound use the 8-zone approach. We found that the lung ultrasound imaging is fewer thinking, different degree of the B line. We can see the B7, B3, and the confronted B line. Subfural consolidation, thyroid signs, and multifocal smaller consolidations. The lung ultrasound imaging illustrates that the disparity failures of the dyspnea is mainly due to virus infection. So for this patient, we see they found the lung ultrasound imaging, the nature is have the B, the most of it is the B, have the B7, B3 confronted, and the small thyroid consolidation, and the error is diffuse. The fever is the sinking and moving. So from that we talk about that the meaning of the respiratory failure is due to the virus related. So for this patient, it's the most important therapy is to antivirus and to wait the time to help the patient recover from the virus. According to the different science, we do the different approach. Considering that the lung injury of the COVID-19 patients is more multifocal and have the characteristic of the bottle up inside-outside license for better screening and high detection rate of the positive license. We recommendation from the 12th zone approach to screen the patients. From this section, the Dr. Chen Mingming will detailed talk about it at the future lectures. And the other respiratory related disease progress is the respiratory driver force. We often see in the COVID-19 patients, the respiratory driver force is increased. For the clinical manifestation, often have the strong spontaneous respiration, increased respiratory rate, and heart rate. and patient maybe have the hyperkinetic heart. From the ultrasound imaging, we can see the lung sliding, fewer motion movement is stretching, and the increased displacement and the sink fraction of the diaphragm is increased. So from this, we can judge if the patients have the respiratory force increased. And sometimes, if the have it, we need to treat the patient to use some of the sedation drugs. For the progress of the circulation related to the respiratory, we know the circulation-related respiratory emergency events need way to pay more concern. The pulmonary circulation is high flow, the low pressure and the low resistance system change with the critical output and the perfusion pressure. So we often see in the COVID-19 patients, it more often have the critical function enhancement, hyperkinetic heart, maybe illustrate the high ARDS incidence. From the 2050 publication in the Journal of the Critical Care, they found that the higher injection fraction, the more ARDS had been found. So it could mean that if the patient maybe have the low critical output, maybe the ARDS incidence is less. And we also need to pay attention about circulation relates. It's the left ventricular dysfunction and the ACP. We know that the left ventricular dysfunction and ACP is another common factor-induced circulation-related respiratory emergent event. Key point of the AIDS is early detection of the abnormal early and to intervention earlier. We will talk about the circulation at the later detail. And the secondary infection is the disease progression for the respiratory. We know the secondary infection are uncommon factor aggravative the hypoxemia of the COVID-19 patients. The image of the consolidation, especially the tissue-like signs, airborne states the secondary infection. This is the 19-year-old female patient, and confirmed the COVID-19. The lung ultrasound declared that the respiratory failure is more likely to due to he is always the supine position for a long time, and the gravity dependent of mirrors, because he have the femoral sinking, just a little B7 line, and most of at the lower the lung is the air program and the gravity dependent change of the lung. So for this patient, with therapy, we need to notice the position of the patient, maybe to do the PPV for the full position to make the consolidation to the open the lung. And just from the lung ultrasound, we can rapidly to find that the patient respiratory failure may be just because it had the improper intervention or the infection. And the other we talk about is the airway obstruction. Compared the double lung movement, we can hyperus to front the airway obstruction. We can see from the right and the left, the double lung movement is equal or not. It may be hyperus to front the airway obstruction, although distinguish the infiltration from atelectasis. Maybe from the ultrasound, from the lung ultrasound, distinguish the inflammation from the atelectasis may be in difficulty. Sometimes, the finding of the sonography air, the bronchogram, suggests that the infiltrative process with airway consolidation. But the static air bronchogram can be seen in the atelectasis lung. So it may be lucid from the lung ultrasound that the patient have the airway obstruction. Just now, we talk about respiratory driver increase. But sometimes, especially longer during of the disease, the respiratory driver is decreased after due to hypoxia, the muscle fatigue, and the drug. So we can by the diaphragm movement decreased or disappeared to judge if the patient have the respiratory driver decreased. The last for the respiratory emergency event to judge is the fewer cavity occupation. We know the pneumothorax is very common complications in COVID-19 patients. The absence of the lung sliding or the presence of the non-specific air artifacts without the normal aeration pattern is a suggestion of the pneumothorax. If the lung sliding is absent and the specific signs is noticed on the M model, cause include massive pneumonitis, atelectasis, apnea, severe acute obstructive lung disease, and pneumothorax. So we can to judge from the lung ultrasound to see if the patient have the pneumothorax. And if you see the lung points, maybe it's the highly specific finding that the rules in the pneumothorax. Even though if we do the lung ultrasound, we see the patient lack of the process of the lung sliding, the lung posture, consolidation, and the balance. It may effectively rule out the pneumothorax. So we talk about just for the respiratory emergency events. And next, we will talk about some circulation emergency events. The first, echo can identification of the true of the and the false cardiac arrest. And it is the better in the ECG and the clinic diagnosis. And the other important side, for the circulation emergency events, to prediction of the severe cardiac advanced event risk is very important. This is the patient, is 17 years old, female. He came from the COVID-19 to admission to the hospital. And in the world after his admission, his respiratory rate is 22. For the no-oxygen therapy, his SpO2 is 99. But one way to when we to do the ultrasound for this patient adjusted to the screen, we found that the patient have the arterial spectral defects. He have the very, very large right arterial and ventricular and the pulmonary arterial hypertension. So we know for this patient, she has the high risk of the cardiac arrest. And for the therapy, we need to avoid the rapid fluid infusion and avoid the hypoxemia and avoid to the blood pressure is decreased. And we need to balance the fluid management for this patient. Avoid the increased risk of the hypertension. So it is a predication of the severe cardio-advanced event risk, and also to tell us what's the therapy we need to do, and to be cautious about this risk. And the patient, if they have the hemogenic fluctuations, the first we just to do to fast rapidly to identification and light the cause. If the patient have the hemogenic fluctuations, point of the care ultrasound can help us to rapidly identification the underlying cause. The left ventricular dysfunction, the right ventricular dysfunction, all the patients have the cardiac tamponade or hypovolemia. For which underlying causes, it just means that we need to have the therapy for the patient to management. And actually, the ACP or the the right ventricular dysfunction is very common in COVID-19 patients. So we know the acute cold pulmonary that just talk about the ACP is a result of the acute increase in the pulmonary arterial pressure that may be attributed to the various causes, such as ARDS or PE. We know the COVID-19 patients often have these two kinds of the emergency events. The ARDS is associated with ACP in 20% to 40% of the cases in ARDS. It may be attributed to the various factors such as regional occlusion of the pulmonary muscular beds and the requirements in the right ventricular afterload, secondary to the compression of the pulmonary capillaries by high platelet pressure, as well as the acidosis and hypoxemia. So monitor of the right ventricular function by the echo examination. It can be helpful in optimizing mechanical ventilation strengths, adjust the tidal volume and the platelet pressure, monitor the effect of the PEP. So for the COVID-19 patient, we found all of the patients don't need the high PEP. Maybe just the 5 to 8 PEP it has the more effect than the high PEP. So from the ACP monitor, it's very important in the COVID-19 patients. The extent of the ACP in COVID-19 with incomplete date to know may be nearly 40 to 50%. We can see this patient. It is a 67-year-old male he have the COVID, confirmed the COVID-19 in the last month. And after he coming from the hospital and admission to the ward, I gave this the high flow. And 19% FiO2, 60 centimeter per minute flow. It may be with the high parameters for the mechanical ventilation. And we do the ultrasound for the patient. For the right ventricular is dilatation. Increment in the right ventricular per left ventricular rate is nearly 1:1. And IVC enlargement. And we also can see the D-shaped configuration of the left ventricular. It have the higher velocity TR flow. So it is a classic patient for have the COVID-19. He have the ARDS. He have the respiratory failure, severe respiratory failures, and have the ECP. So for this patient, we need to give the patient the trachotubal and to have the PPV ventriculation. And maybe the patient need to do the ECMO. And the PE, the pulmonary embolism, is associated with the right ventricular dysfunction. In some cases of the PE, the colloid may appear as mobile structure in the right ventricular arteriole as well as in the right or the main pulmonary arteries. If we can see the clot in the right or the main pulmonary arteries, we can confirm the PE, the diagnosis. Recently, the Dr. Chao from the Beijing had published a retrospective cohort study. For his study, he found the dimer is the high risk of the old age, the high sulfur score, and the dimer maybe have the clinicals to identify the patient with a poor prognosis at an early stage. We know that the dimer is the high rate of the embolism. So for the patient, we need routinely use the echocardiographers to evaluate right ventricular function to optimize the management of the mechanical ventricular patients and the other therapy in COVID-19 patients. So the other dynamic left ventricular outflow tract obstruction is not an uncommon feature in the ICU, such as the preload, afterload reductions, the heart rate increased, or the contract thickness of the heart increased. Maybe all of the Earth make the patient in ICU to be very common to have the dynamic hemodynamic of the left ventricular outflow tract obstruction. From this kind of the patients, as the pathological precipitation factor is often necessary, but the anemic structure may be not necessary. And in the COVID-19 patients, also anemic admitting structure-related factors are not necessary. But when we do the echo to the screened patients, when we see the full kind of the structure to be one of the patients, maybe to have the obstructive shock of the dynamic left ventricular outflow tract obstructions, as well as the patient have the myocardial hypertrophy or have the fast atrial fibrillations of the left ventricular hypertrophy. Maybe they be easy to have the genic left ventricular outflow tract obstructive. So if the patient have the shock or have the blood pressure lower, we need to caution it and do the ultrasound and to see what happened for the patient. It need to more fluid or need to give to increase the blood pressure, the pressure, or we need to the sedation for the patient. You just found it, you can know how to celebrate. And the last circulation emergency event is the stress cardiomyopathy. We know in the COVID-19 patients, because the inflammation is very higher, that most of the patients for the IL-6 and the other inflammation factor is increased. And the patient is in the very high stress force. So this kind of the patient often have the stress cardiomyopathies. So we need to screen the patients. When we do the ultrasound for the echo for the patients, if you found the patient have the stress cardiomyopathy, you need to know that the patient the stress is increased, and we need to do the more and more sedation for the patient. It will be the therapy for the patient. We talk about the imaging event about the respiratory and the cardiac. There are also the other organ have the emergency event of the severe COVID-19. We know that the COVID-19 may be often at the last stage of the disease. He have the MODS. Some patients have the AKI. He have the oliguria. Some patients, most of the patients have the acute gastric injury. And some patients have the liver injury. And last week, we see a patient in the ICU have the spleen bleeding. So we also can do the fast screen to distinguish the abdominal bleeding. And a lot of the patients at the last stage have the sepsis. And we also use the echo to find the infection screen with the site of this patient the infection. And we can also use the ultrasound to the management causal or ECMO and CRT. So from the head to the respiratory, cardiac, kidney, liver, and the other abdominal organ from the sepsis causal, we all of us can do the ultrasound. To predication, if the patient have the risk to be the emergency event, and we can to according this to give our therapy treatments. So we have the summary of this topic. We know the COVID-19 patient is all over the world, and it is a new disease. We just know everybody have the no appearance for this kind of the patients. Because of the some limitation, often the CT scan and the other monitor maybe have the a lot of the limitation. But the critical care ultrasound is the effective method to evaluate the emergency of the patient with COVID-19. For this kind of the patients, hypoglycemia, respiratory failures is the main clinical feature. So when we use the critical ultrasound, it can be play a guiding value in the rapid judgment of the cause of the hypoglycemia in patients with the COVID-19. Just as we talk about the two types of the COVID-19, maybe we can rapidly to judgment. It's just because the virus directly infect the lung, cause the severe respiratory failure, or maybe he have the secondary injury such as the sepsis to cause the severe respiratory failures. We can just by the lung ultrasound to judgment. It is the superior. It is a superior to the epithelial cell secondary injury or the superior endothelial cell secondary injury. It is very helpful for us to the management of our patients. And also the critical ultrasound is an indispensable means to solve the emergency circulation event, such as to find the ACP and to find its cause of the ARDS or the PE. So when we screen by the ultrasound, when we do the critical ultrasound, the early warning to avoid emergency help us to avoid the emergency event. We think it's very important to reduce the incidence of the patient emergencies. It can also minimize the recurrent operation of the patient and also can reduce the risk of the infection among the medical staff. So after we arriving at the Wuhan, for the CCUSG, the group, so maybe 34, maybe the 30, about of the 34 the doctors belong to the CCUSG, also working in the Wuhan. And we together to communication each other and write this communication for the doctor to manage of the critical ill patients based on critical care ultrasound. It has been published online and accepted to publish on the Chinese Journal of the Internal Medicine. We think that the COVID-19 is a new disease. And this is a war, and we are all fighters. All of us believe that we can fight them, we can beat them. And the dawn is breaking, and we are seeing light coming through. Thank you for your attention.
Hi everyone. Just now, Professor Zhang Lina take an excellent lecture for us. Her lecture have rich content about COVID diagnosis and treatment, especially about stratification and early warning of the critical COVID-19. It's an important part of the COVID-19 uh, treatment and diagnosis. Uh, Hi, it's time to question and answer. Let us invite Professor Zhu Ran to organize this important section about question and answer. Hi.
And thank you, Xiaoting. Thanks for Professor Zhang Lina and Professor Wang Xiaoting. And I'm Dr. Zhu Ran. I will host this Q&A session. Here we have a lot of questions from our audience. I will pick some meaningful questions and ask one of my colleagues to answer it. The first question we got from our audience is how to distinguish between primary and secondary damage. I think this question will depend on which organ we are talking about. Is primary injury or secondary injury to the lung or to extra lung organ? So I will ask Professor Wang Xiaoting to answer this question. Please.
Yeah. Thank you for your important compliment about this question. It's a great, maybe it's a good question about just there's maybe in plus lung. It's good. It's primary and secondary lung injury, lung damage. So as we all know, COVID-19 its important pathogen is SARS-2 virus. It's a very severe and it's serious. The serious infiltrate into the lung deeply, and so in the very beginning, in the early stage of the COVID-19, especially critical COVID-19, the virus damage injury, the alveoli, especially the epithelial cell, and then maybe the protein and some liquid and exudation and infiltration and makes the membrane of the alveoli become and bigger and stronger, and then damage the oxygen exchange. So patient got a severe respiratory difficult and acute hypoxemic respiratory failure. So in the very beginning and in the early stage of the critical COVID-19 patients, it's a primary lung injury. And then maybe the lung injury, it damaged, injured by the virus, become severe and severe. So the patient got severe stress and very severe respiratory strong and stronger respiratory driver, and then the patient maybe got a secondary damage, secondary lung damage, just like endothelial cell injury. So maybe when the patient got a severe endothelial cell injury, the liquid, maybe the fluid liquid become the more severe and severe. Patient got a severe respiratory difficulty and saturation of the oxygen decrease very severe. So the secondary injury of the lung, maybe damaged by the endocellular cell and severe fluid leakage. So maybe you give a patient the ultrasound examination, maybe a CT scan. You find some special findings of the lung, especially consolidation. If the patient got a lung consolidation, the consolidation becomes severe and severe. Maybe it's demonstrated that the patient got a secondary lung injury. So how to distinguish the primary injury and the secondary injury? Maybe depends on the degree of the consolidation. So it's an important sign, important findings of the lung injury. Thank you.
Thank you, Professor Xiaoqing. And I think Professor Wang Xiaoqing just talked about the mechanism of primary and secondary injury to the COVID-19 infected lungs. And I still think as a clinician, we need to look for some clinical manifestation to convince there is some underlying factors like fluid management, mechanical ventilation settings, or sepsis, secondary hospital-acquired infection in the lungs. So this must have some relation to the secondary injury to the lungs. So we just relate the clinical manifestation to what we have found by lung ultrasound in the COVID-19 infected lungs. So that's my opinion. Thank you, Professor Xiaoqing. Yeah. We have some other questions. Here is one. Initial work on patients suggests that lung ultrasound may be useful in the evaluation of critically ill COVID-19 patients. Patient at which stage of severity is it needed for echocardiography? So I will ask Professor Chao Yengong to answer it. Please.
Okay, thank you, Zhu Ran. In my opinion, I think most of the doctors who use echocardiography is most focused on circulation management, especially in these very severe stage patients. I think you can use this machine, use this kind of tool to help us. But in the COVID-19 patients, I think lots of things is something different between the other critically ill patients. So based on this kind of disease, from the clinical manifestations, we think the patients will be separated into different levels. Some patients maybe the prognosis is very good, but some elderly and also people with some chronic underlying disease which have very poor prognosis. So I think this different patients we use this ultrasound machine can help us to triage or degrade the patients to different group or separated in different group. So I think this machine is first is triage tools. And then, some patients I heard from my colleagues from Wuhan, from Hubei province, they give us a very strong opinions or impressions like that is, so some patients suddenly to become very severe and the circulation and the respiratory function get worse very rapidly. So I think in this kind of conditions, something is related to the stress or related to some patients, I think, worse very fastly. But in this phase, you still need to use this kind of a machine, especially combining the lung ultrasound and also cardiac ultrasound put together to see what happened with the patients. And also, in this kind of patients, we all have this kind of experience. You don't have a lot of tools or how to say the chance to take some evidence from patients to see which patient is coming to more worse, more severe, or which patients is getting better than before. So you should put more your eyes or energy focus on the causes of these patients to see what happened with the patients. So in this phase, you see a lot of patients. I think psychologist part, the patients also have very strong the pressure. So I think you use this kind of a machine to try to figure out which patients under very strong stress. I think it's also very useful. So let me summarize this kind of ideas. The first, in maybe the early stage, you try to find some patients have some underlying disease, chronic disease, especially in the clinical circulation part, chronic heart disease, these things. And also we use this machine try to figure out what patients will become more severe or have a poor prognosis. So this I think is one of this kind of using method. And second, the patients when the patients become more severe, the circulation, I think this function now is getting worse. So we need more focus on the patients, the monitoring and interventions. I think during this phase, the echocardiography is very, very useful and strong tools to help us. And also this disease, I think the most important characteristics is the lung damage and also ventilation function is very, very bad. So you have to use your ventilation ventilator, use some kind of even the ECMO. So most of the patients, not only the lung epithelial cells or the alveolar damaged, and also the vasculars, the right heart, right ventricle, are also damaged. So when you treat patients or you intervene to your patients, give some kind of treatment, you have to under your very close monitor. So we use now in this stage, we use our echo, use our ultrasound, and put that together to monitor our patients, even titrating our treatment to give the patients helps. And also during the very late stage, we have some very severe perfusion function of the patients. This kind of information sometimes from maybe from brain circulation or perfusion or from our kidney or our livers. So this kind of perfusion or circulation function, we also can use our ultrasound from some PW, CW, some kind of blood flow information. So we combine this information and integrate this information with some clinical information together. We will help us, help our patients. So this is my ideas. Thank you. I think I can give the back to Dr. Zhu Ran.
Thank you, Professor Chao Yingong. I totally agree with your comments. And I think except for echocardiography could help us with management of hemodynamics and monitoring or differentiated diagnosis of the emergency situation. I think to screen for some chronic condition of our patients is very important. For most of the severe COVID-19 patients, they have multiple comorbidities. So if we have echocardiography to tell us there is some chronic change of their cardiac output or cardiac size of the cavity, so maybe we can have some pre-treatment to this severe patient. Yeah, thank you. Anna has some other questions. One is, what kind of critical events we will face with the COVID-19 patients if ultrasound is the first choice for the situation? I think this is just a topic for Professor Zhang Lina, so please.
Thank you. It's a very good. It's a good question. For all of this topic, is focused on the emergency events. For Chinese experience, according to the patient clinic, we classification the patient to the four kind of. The first is mild cases. This kind of the patient, the clinical symptoms are mild and no pneumonia manifestations. And the second is ordinary case. The patient only have the simple times like the fever and the respiratory tract symptoms. The third is severe case, and the last is a critical case. I'm now working in Wuhan as in the critical ward. We just to receive the severe case and the critical case. For the severe case, it's just meeting any of the following for the respiratory distress, that the respiratory rate is be higher than 30, and his the oxygenation index may be lower than 93%, and the for SpO2 is lower than 90%, 93%, and the oxygenation index is below 300. So for this kind of the patient, the most common emergency event is respiratory failure. In the last, just at the last month, most of the patients have severe hypoxemia, dyspnea, but when he is at rest, it's not obvious. We often found the patient have this emergency event after they go to the toilet or have the eating some the food, or sometimes you'll be all of them be found to the fall on senses. So we must to caution our doctor to caution that the respiratory failures. So we recommendate all of us to, when the patient coming to the world, recommended to do the screen, the ultrasound for all kind of the patients. You can to find what the patient, the lung lesion serious, and it's serious, it's degree of the lung lesions, and you can to give the right oxygen therapy, and you can to avoid the patient to the critical events. So the first event is the most common in the COVID-19 is the respiratory failure. And the next, sometimes the patient maybe have the shock. The shock may be due to the fever shorts, and sometimes maybe the PE, because the the patient is often to live in the bed for a long time. So the other for sepsis is not very common in the COVID-19. If the from the second question, you ask if the ultrasound is the first choice for the situation. Actually, is yes, and maybe sometimes is the only tool we can choose, because we know that the COVID-19 patient a lot of the amounts in all of the world. From the last month in Wuhan, it may be when we want to take a CT scan, often we need to wait 3 or 4 days to finish it. And we need to transfer the patient from the ward to a long distance to some special situation. So sometimes you cannot do that to do the CT scan, and often that the X-ray is cannot to be avoided. So in a lot of time, and many situation that maybe the ultrasound will be your only tool and is the first tool to choose to front the critical event that you can to choose the tool.
That's all.
Yes.
Thank you, Professor Zhang Lina. So, any other comments from Professor Chao and Professor Xiaoting?
No.
No? Okay.
Thank you.
So I'll keep going. Next question we have, is ultrasound valuable for pulmonary fibrosis in patients with COVID-19? I think that's a very valuable question that I will try to answer it. From my point of view, I think for the first part of this question, the answer is yes. Lung ultrasound is valuable for pulmonary fibrosis, but for COVID-19, we just don't have the confirmed result of what's the pathology or pathophysiology of the COVID-19 patient's lung. So we even don't know if it is going to be chronic fibrosis with a result of lung transplant. So for the first part, I will answer for pulmonary fibrosis. We could use lung ultrasound to examine the patient's lung from the different level. The first, we need to differentiate the etiology of pulmonary fibrosis. Like if we have some patient from the respiratory department, we might got some patient with chronic pulmonary fibrosis. Or we will have some acute interstitial pneumonia with pulmonary fibrosis, but at the early stage. So the second level is we need to differentiate the stage of the disease of this patient. So for an acute onset patient, maybe we could find more B lines or irregular B lines for this patient, and some interstitial syndrome for this kind of patient. But for some chronic fibrosis patient, maybe we will find some irregular B lines, and we will find some distribution of the B lines inside his lungs, and there must be some pleural line, the change of the pleural line in this chronic fibrosis patient. So we can conclude the lung ultrasound pattern of the pulmonary fibrosis to differentiate what kind of patient your patient is. So we need to find what kind of B lines of your lung ultrasound of your patient. So it is regular or irregular, the distribution in which part of the lung, both right lung and left lung, the upper and the lower, or the front or the back of the lung. And the second, we need to examine carefully with the pleural line. So if you get a smooth pleural line, maybe your patient is in the acute stage of the pulmonary fibrosis. And if you get a coarse pleural line, maybe your patient is in his chronic stage. And the last one, I think we need to combine all the signs in lung ultrasound together. That means the lung has the function of ventilation. So if the pulmonary fibrosis patient, they will have a stiff lung, their ventilation is poor. So the pleural line, the pleural sliding must be small. You could only find a small motion of the pleural line, pleural sliding. So that means your patient lung is very stiffened. So this is just a sign we could find in our severe COVID-19 patient with a very poor compliance, and we could just ventilate with a tidal volume of just 100 to 200 mils to their patient. So you can see some coarse pleural line in your patient over 1 month, and you could see all kinds of B-lines in your COVID-19 patient very severely, and you could see your patient with poor sliding in your mechanical ventilated patient. So that's my comment to this question. And any other comments?
Yeah. What the Professor Zhu Ran mentioned about the lung ultrasound play a great role in management of pulmonary fibrosis. Just like what the Professor Zhu Ran mentioned, I think there's maybe four key points. It's just about lots of COVID-19 patients experience long time exudation and infiltration, and then became severe and severe, and then when the patient got better, especially 1 month, after 1 month, 2 months, 3 months, patient often got pulmonary fibrosis. It's the one key point. And the second one, just like Professor Zhu Ran mentioned, I think the lung ultrasound can give three findings. The first finding is pleural thickening and alteration, and maybe the pleural movement decrease, maybe pleural membrane, pleural extrusion, and became weak. And the second one is he mentioned is all of the B-line signs. Maybe when patient got pulmonary fibrosis, maybe you can see lots of uneven B-line. Uneven line is more often. So it's key 3 points, maybe 4 key points. It's my mention. Thank you.
Thank you, Professor Xiaoting. Anyone else? No?
Yeah. Yeah.
Oh, okay. So we move to the next question. Here we got a question. Once you identify the early warning signs with ultrasound, which are the measures you take? So Professor Xiaoting.
Hi, it's my turn too. Thank you. It's my favorite. It's a good question. Maybe there's just like what the Professor Zhang Lina take excellent lecture. A lot of context about early warning signs. I think maybe the first one, the circulation related critical events about early warning. Maybe just like you take in the very beginning, patients got a hypothermia, maybe a very severe respiratory difficulty, and you take a lung examination. Ultrasonic examination for the patients. If you find the patient got lots of B lines, and then a great sign about the heart is that it's hyperdynamic heart. It's very active. So maybe you see these signs of a heart hyperdynamic. Maybe you can take a detailed examination for the patients about the signs and the simple symptoms, combined the lots of clinical manifestation. If patient saturation of the oxygen is very lower, and then respiratory situation is very difficult, and the patient got a very severe stress, just like anxious, maybe emotional fluctuation. Maybe if you take a detailed psychosis evaluation for the patients, the patient got very severe, delirium. So if the patient you take echocardiography examination, you find a hyperdynamic of heart, you can find the lots of clinical manifestation. Demonstrate that patient got very severe stress. So the first measure is to take optimal sedation for the patients. Just like the first sedation and maybe the lots of method to keep the patient calm down. It's the first method to it's the first measure. And then if you can see patient got a very severe heart disease, just like stressed myocardium disease, just that is to say apical balloon syndrome, broken heart syndrome. Maybe the keep the patient calm with the sedation is very important. It's the first, and the second aspect, it's I think maybe the respiratory critical events is very important, very often. If the patient got a very severe hypothermia, maybe patient got pneumothorax, it's very severe, and patient got very lower saturation of oxygen, and maybe the circulatory collapse. So it's the first method is to take a long examination for the patient and make an exact diagnosis of the pneumothorax, and then take the exact measure to treat the patient. It's very important. And the third, combine respiratory events and the circulatory events. It's just like acute right ventricle dysfunction, just like ACP, acute cold pulmonary. It's in the later stage of the patients. If the COVID-19 patient got critical and got severe and severe, you can often find the ACP. So if the see the ACP, you can take the first measure to keep up the patient calm down, and then the very important another important measure is to and adjust the mechanical ventilation support level, just like a PEEP, just like a tidal volume, just like and the pressure of the air pressure. So what I mentioned about the about the critical events of the early warning sign we identified the early warning signs with ultrasound. I will do lots of measures to treat the patient. It's my opinion. Thank you.
Thank you, Xiaoting. That's very in detail. So we have 7 minutes left, so we must be quick as we could. Let's move on to the next question. And I guess this question is asking, when is ultrasound required in the early stage, I mean in the fever stage of COVID-19? So I will ask Professor Zhang Lina to answer this question, please.
Yeah, okay. I think that this question wanted to ask if the patient have the fever when he come to the outpatient. Is he can to confirm that he is COVID-19 or the other pneumonia or the other causes due to the fever. So I think the ultrasound may be helpful in this situation. If you can, if that cannot to do the nucleic acid detection, and there are not enough time to do the CT scan, or CT scan maybe the negative, you can do the ultrasound. It's just to take 10 minutes at the outpatient. If you found that the fever patient, the lung ultrasound have the fewer sinking or the different degrees of the B line, and maybe some have the subfural consolidation. I think that the patient maybe it's the COVID-19 is probably. So you can just use the ultrasound to the first line to rule out. I think it's if you cannot to do the CT scan or the nucleic acid method, you can take the ultrasound to be happy to diagnosis on the fever, the earlier fever patients.
Thank you. So our next question is, what is your experience in diaphragmatic excursion? I think we all have some experience in measuring diaphragmatic excursion or ultrasound in diaphragmatic measurement, but I don't think we have so much experience in COVID-19 patient. So when we use ultrasound to measure diaphragmatic movement, I think there are some conditions we must remember in our mind. That is, we usually we could just use ultrasound to measure diaphragmatic movement in spontaneous breathing patient. So the effect of mechanical ventilation will be the minimal. And when we use ultrasound to measure diaphragmatic excursion, it is not correlated or equal to the ventilation or tidal volume of the patient. So we just measure the diaphragmatic excursion together, sometimes together with the diaphragmatic thickening. And when you use the diaphragmatic thickening as an indicator for your patient, you must remind or keep that in mind that there will be, it's a very thorough or very thorough measurement. So there will be some error in the techniques. That means 0.1 millimeter to 0.2 millimeter. So that will make some errors in the measurement. So techniques may be your key point in this measurement. And in COVID-19 patient, I think some of our guys in the front line, they will use the ultrasound to measure the diaphragmatic movement in some spontaneous COVID-19 patient. We just want to know how severe this kind of patient, they have the respiratory drive, and they have very negative poor pressure. So that will cause the spontaneous breathing induced lung injury. So if you could not find your patient with some strong spontaneous breathing from just the auscultation or from the just looking at the chest, maybe you could use a lung ultrasound to see the diaphragmatic movement of your spontaneous patient, spontaneous breathing patient, to tell you how strong spontaneous breath your patient has, and to predict how severe the spontaneous breathing induced lung injury in your COVID-19 patient. So that's my comment.
I totally agree with you about, I think maybe diaphragm excursion of diaphragm ultrasound will have an important role in the future, in the now. And what you mentioned about the strong respiratory drive and respiratory fatigue, both is very important to early find these two conditions. So if you can early find the strong respiratory drive and the respiratory fatigue, and you can use a diaphragm ultrasound to select the optimal respiratory standards, and then to avoid both. The first one is to avoid the lung injury, just like what the Professor Zhu Ran mentioned. And the second one is to avoid to vein failure. So it's my opinion. Thank you.
Yeah, I just forget the winning in the winning process. Yeah, thank you.
Yeah, fatigue.
So we have, in fact, we don't have time, but I think we have a valuable question here. So we will have this question as a closer question. This question is lung ultrasound has some effect or predictive effect for prognosis in poor positioning? So how about Professor Chao Yinggong?
Okay, so I think it's the time very limited. So I think most of doctors is very familiar with, especially in our intensivist or in ICU. So most doctors are very familiar with this kind of mode of the ventilation. So, but in this kind of patients in COVID-19, in the very early stage, based on the from pathology part, we saw that most of the patients in early stages just some GGO, we call it ground glassy opacity. So it's just it damaged the peripheral or very details distal of the lungs. So in this part is we use this kind of machine is not very useful, but in the prone position, as published from survival sepsis campaign guidelines, just published several ago, they also recommended this treatment method, use PPV. So I think it's useful. In this area, the critical care ultrasound, we can use it to just in the first stage, you try to separate a different group of patients. First is some based on the damage of the lung. If the patients have maybe the gravity dependent area in the lung, you see it's not we see hyperventility condition. So you can use this mode of treatment or interventions, help your patients. And also you can use a lung ultrasound to select some patients have the potential to have a reaction to the prone position. And also we can say use this machine to help us to see what kind of changes of the patients when you give the position change, to see the patients, is there any change of the disease or the shape of the lung or the physiological part of the lung or even circulation. So we use lung ultrasound to try to separate these patients, to monitor your patients. And also we use ultrasound combine some echocardiography to see the circulation part. You know, some patients not only this the lungs is damaged, and also the hyper pressure of the pulmonary arteries. So the right ventricle was damaged. So you will see sometimes the enlarged right ventricle, and also some septal is become movement is very difficult to see the ratio between right and left ventricle. So in this condition, you also telling you to use maybe prone position to lower some maybe ventilation tidal pressure or the other things to help your patients. So I think this kind of machine can help us in this area. And also but I should say, you know, the time is very limited. We should say we don't have a lot of experience to see this kind of prognosis values in about this machine or the method. You know, we don't have a lot of experience, so I don't know how to tell you about this. So this is my opinion.
Thank you, Professor Chao Yanguo. I think we will leave all the unanswered questions to next session. And now I will ask Professor Zhang Lina, our speaker, to make a summarize to her presentation. Please.
Okay, thanks, Drew. Thanks, everyone. I want to say that the COVID-19 is a new disease. There are a lot of things we are all unknown, but the reduced incidence of the patient emergency. It means that minimize the patient risk of irritation, and we also can reduce the risk of infection among the medical staff. So for this, the creative ultrasound is an effective method to evaluate the emergency of the patient with the COVID-19. So maybe it's the only tool that we can take care of my patient. And I believe that all way to beat the COVID-19, and I believe that the dawn is breaking and we are seeing the light coming through. Thank you, everyone.
I think we need a nucleic acid test on Professor Zhang Lina. Take care. Thank you, Professor Zhang Lina,
to everyone.
Thank you, Professor Zhang Lina, for your excellent presentation, and thank you, Professor Wang Xiaoting, Professor Chao Yanguo, for your excellent comments, and thank you for our audience. And here I will focus our next speech on next Tuesday. Is from Professor Ding Xin in Beijing, and he will give us the topic of the application of a critical ultrasound in biosafety level 3 ward. So let's welcome expect next Tuesday. Thank you.
Okay.
Thank you. Bye.
Bye.
Bye-bye.
Bye-bye.
Bye-bye.